Hi guys, I'm going to finish the rest of our cardiac lecture. I'm going to just voice over our PowerPoint to make sure that we can get in the rest of this material. So I am going to backtrack a couple of slides because I think we were really tired at the end of last week, and I'm not sure how much you actually were able to take in at the end of that class. I know everybody was pretty wiped out. So I'm going to go back to this slide, which is a picture of the fetus. And remember, the fetus is actually not oxygenating. Gas exchange does not occur in the lungs of the fetus. It occurs in the placenta. So maternal blood is bathing the placenta, and through osmosis and diffusion, oxygen is going to diffuse into fetal circulation. Actually, just a fun fact, the maternal blood and the fetal blood actually never mix. All osmosis, diffusion, active transport, all of those reactions are occurring here in the placenta without blood needing to mix. So the fetal blood is his own blood in circulation. So the placenta, the umbilical veins, are going to carry oxygenated blood back to the fetus, and the first shunt that we're going to encounter is the ductus venosus. So the ductus venosus is going to occur up in here where this umbilical vein, and the umbilical vein is carrying oxygenated blood to the fetus, is actually going to dump right into the inferior vena cava and carry that oxygenated blood into the right atrium. Now at birth, when this umbilical cord is clamped, there's some pressure changes that occur, and that pressure change is going to cause that ductus venosus, which is no longer needed, is going to cause that to close. So that closes within minutes after birth once that cord is clamped. The next shunt that we're going to talk about is the foraminal So the foraminal is up here in the right atrium. So in the fetus, blood is shunted right from the right atrium through that foraminal into the left atrium. So bypassing pretty much most of the lungs. Now, not all of the blood is going to pass through there, but most of it does. This avoids the pulmonary valve, and it's avoiding taking all of the blood in back through the lungs, because remember, the lungs aren't the parts that are doing gas exchange for this fetus. Again, after that cord is clamped and those pressure changes occur, that foraminal is going to close within minutes after birth, very quickly after the cord is clamped. The last shunt that we're going to talk about is the ductus arteriosus, so that's right here. The ductus arteriosus is taking blood right from the pulmonary trunk here into the aorta, right into the aorta, again bypassing the fetal lungs. Now the ductus arteriosus does take a little bit longer to close. This one can stay open for several hours after birth, and we can sometimes hear murmurs in babies after birth due to this shunt still being open. So the fetal circulatory system, the goal of it is we are bypassing oxygen exchange. It does not occur in the lungs. We're kind of bypassing the lungs. We're relying on the placenta. So we have these shunts or passageways, if you will, in these vessels and through the heart to bypass the lungs. So fetal circulatory system. Next, this is just written in words what I just told you, and also kind of explains what happens. I wouldn't go too crazy worrying about this. If you are a person who likes to read what happens instead of seeing a picture, this may be helpful for you. There's also some things that occur, like oxygen is going to be a vasodilator, CO2 is a vasoconstrictor, but that might be going a bit above and beyond what we really need to know right now. So just a little more FYI information. Okay, cardiac assessment as the child grows. Okay, so in a newborn, we have our pulse rate is going to be a lot higher. So a normal newborn heart rate is going to be 110 to 160, so a lot higher. As the child grows older, that heart rate baseline is going to start to decrease as the child gets older. We also have a smaller heart, and our heart is a bit more horizontal in the child, so that apex rises a little bit, and instead of the fifth intercostal space, it's located at the fourth intercostal space, mid-clavicular line. As the child grows older, usually by about age 7, that apex is going to be at the adult spot. So another thing to take note of in infants and smaller children is that their heart rate speeds up and slows down during respiration. So you notice as the child inhales, their heart rate may speed up a bit, and as they exhale, it slows down. So because this happens when we listen to the heart rate in small children, especially infants, we're going to listen for a full minute because that heart rate is a bit irregular with inspiration. Another thing you may notice if you assess heart rates in smaller children, especially infants again, is that their chest wall is much thinner. So everything is going to be louder. So you really have to focus on the heart rate when you're trying to gather that information. Sometimes it helps to tap your finger or tap your foot to try to get the rhythm of that heart rate when you're counting that apical pulse. It could be normal in children, again, to hear a murmur in the first 2 or 3 days after birth due to that ductus arteriosus still needs to close within those first few hours. One thing to take note of is sometimes there can be cardiac defects in infants. And we really try to screen children to pick up on those, but sometimes we don't. Also, these can lead to, sometimes there's pulmonary hypertension that infants can be born with. Infants can also suffer from congestive heart failure. So things we want to watch when we are assessing babies is, do we have any cyanosis when that child is eating or when the child is crying? So if they're eating, they really have to be able to focus on suck, swallow, and breathe, coordinating all of those things. And if they have congestive heart failure, we have a cardiac defect. Sometimes if they are sucking and swallowing, we get some cyanosis that occurs. Another thing to watch for if that child has heart failure or cardiac defects, it may take them a long time to feed. So it's taking them a long time and they get really tired with feedings. They are taking fewer ounces than you would anticipate. It takes a lot of calories for an infant with that heart failure or congenital heart defect. It takes a lot of calories for them to eat, and so they may have failure to thrive. They may not be growing as they should because their metabolism, they're using so much and burning so much calories when they're trying to feed. So they have poor weight gain. We see color changes with feeds. They could also have developmental delays because of that increased metabolism demands, and they're not acquiring as many calories as they need to obtain those developmental milestones. Okay. So just some things to watch for cardiac-wise in small children. Okay. Then we're going to move on lastly to elderly, changes in the heart with the elderly. So sometimes it's really difficult for researchers to know what are changes related to becoming older versus changes related to lifestyle. So things like our diet and smoking, tobacco products can really do damage to the cardiovascular system. Sometimes even occupations where they're working in a lime quarry or in places where we could have been inhaling asbestos, exposed to tuberculosis, coal miners. So was it things, lifestyle issues that were causing cardiac changes, or are they actually related to becoming older? But some things we do know is that as people grow older, their vessels and their arteries start to thicken or stiffen. That's caused by collagen and calcium deposits in those vessel walls, and they become less elastic. So because of that decrease in elasticity, we get an increase in systolic blood pressure and hypertension. That stiffening of those blood vessels can also cause arteriosclerosis, which can lead to turbulent blood flow. It can cause that lumen of the vessel to become smaller, We get left ventricular wall thickening because the heart is having to work harder to pump blood out into those stiffened vessels. We can also get some dysrhythmias related to age and EKG changes as well as that heart starts to grow older and is working harder. The risk of coronary artery disease increases with age because of those changes, hypertension, like I said before, and those can both lead to heart failure as an adult grows older. Okay. This leads us to some abnormals, which we are going to see more of in the elderly, but you could also see these related to lifestyle issues, people who are sedentary, again, smokers, poor diet, lack of exercise. We can see heart failure. So you're going to see different signs and symptoms dependent upon which side of the heart is having problems. So if you can remember, if you still have that drawing that we did last week of the heart, and you remember that superior and inferior vena cava are bringing blood, unoxygenated blood, back into the right side, the right atrium. If that's not working, so far the right side of our heart is failing. We get blood backing up into our peripheral vascular system. So we're going to start to see things like jugular venous distension as blood cannot get into that failing atria. It's not pumping effectively. It's not squeezing blood into the right ventricle or in through the pulmonary valve. As that blood backs up, it can cause our liver and spleen to enlarge as we get that backup of blood. It can cause ascites, which is blood is going to start to leak out of those vessels. That pulls proteins out, and with proteins leaking comes fluid out, and we get this swollen abdomen or ascites. We're having less blood flow into our pulmonary tree and into the left side of the heart. So as we have less blood coming into the left, we have less blood being pumped out. So we start to feel tired and fatigued. We're not pumping blood out on the left side, so we start to retain fluid. We get weight gain because we're not perfusing our kidneys. We're not voiding as much because our kidneys are not perfused. As we're up and at, working throughout the day, up and out, we get this dependent edema as the blood is being pulled down into our lower extremities. So these signs and symptoms could indicate that we might be having some right-sided heart issues. If the left side is not working well, we're not pumping blood out, oxygenated blood out to the left side or out through the aorta into systemic circulation. So if that blood is not being pumped out of the left side, it's going to back up into our pulmonary tree, and we're going to get pulmonary congestion. Fluid in our lungs is going to cause cough, blood-tinged sputum. We can hear wet lung sounds. Those are things like wheezes, crackles. Tachypnea can be a sign that there's fluid building up in our lungs. We can be confused, changes in level of consciousness as we have less blood, oxygenated blood being pumped out of that left side. We have less oxygenated blood getting to our brain, so we can have changes of level of consciousness. Restlessness often comes before the confusion. We have orthopnea, dyspnea on exertion. So this is the person that needs to sleep with multiple pillows at night. When we start trying to get up and do things that we've been doing during the day, we get exertional dyspnea. Fatigue, we could see cyanosis in this person. We could see clubbing in their fingers. So all of these could be signs that there is some left-sided heart failure that's occurring. So how can we encourage, as we are seeing people throughout their lifespan, how can we encourage heart health? So many of the risks that are associated with heart disease are modifiable, meaning that we can do things in our life early on to help prevent cardiac disease from occurring. So risk factors such as hypertension, high cholesterol, diabetes, obesity, sedentary lifestyle, poor diet, we can do things to modify those. So teaching people how to have a healthy diet, what kind of exercise, being active in their life. And these could be things as easy as, and you guys all know this, maybe parking in a parking space that's farther away. Take the steps instead of the elevator. There's many promotional things that go on in our communities, like hikes that take place. In Lebanon County, we have something called Wellness Wednesday, which is going on from the Good Samaritan Hospital, and that's encouraging people in the county to get out and be active. So participating in some of those programs. Making sure that we're getting screenings, that we have our regular checkups, and that we're having blood pressure screenings. We're getting our cholesterol checked. We're having our glucose levels checked to screen for diabetes and high cholesterol so we can intervene early before vascular changes start to occur. One other thing to note is that women, as they get older, and I think we did talk about this a bit, as they enter menopause, they lose estrogen, which can have some protective benefits for the heart. So their good cholesterol, their HDLs, decrease, and their LDLs, the bad cholesterol, increase once we go into menopause. So we need to really educate women on signs and symptoms of myocardial infarctions, of heart attacks, and encourage screenings for women, especially in those menopausal years. We also, have some cultural differences when it comes to heart health. So there actually is African American women and Hispanic women are at much greater increase for heart disease than are Caucasian women. So it's very important to encourage those communities to get out and have screenings and get some education for them so we can help prevent some of these cardiac illnesses and hypertension from occurring. Probably one of the biggest modifiable risk factors that we can teach people is smoking cessation. And again, if someone's going to make a change, they really have to be open and ready to make that change. But if we are talking to them about smoking cessation at each point in time of care, maybe we could get that person and we could get them to make a change in their lifestyle and to stop smoking. Increasing fruit and vegetables in our diet can help with heart health, weight reduction, and then again those cholesterol, blood pressure screenings, and glucose screenings as well, so we can catch illnesses early. Okay, here is just some sample documentation that you can take a look at after you assess the cardiac system. So I'll just give you a second to look at that. Okay, and then our first practice question we're going to come to here. I'm going to give you a second to read it. Okay, so we are placing the diaphragm of our stethoscope on the left midclavicular line, okay, the fifth intercostal space. So which of the following heart sounds are we attempting to auscultate? So we're at the fifth intercostal space with our bell. Should we hear a ventricular gallop? No, we should not. We should, at that spot, we can auscultate the closure of the mitral valve. I'm just going to take you to the rationales here. So B is correct. We should be able to hear that mitral valve close at that fifth midclavicular space, a midclavicular line at the fifth intercostal space. We should also be able to auscultate closure of the tricuspid valve at that point. So the tricuspid and the mitral valve at that apex of the heart. Okay, so I think that's it. We should get some time to practice in class. You can also watch cardiovascular assessment on ETI if you'd like, and also the video link that you see in your weekly guide also has a video on assessment that you can take a look at. If you have any questions, you can feel free to reach out to me via email or during office hours or anytime you can stop by. Let me know if you have any questions.